In the next several weeks, we will cover the scientific evidence that supports the health benefits of participation in regular physical activity and exercise. We will also review the potential health risks associated with a lack of physical activity. In Module 13, cardiovascular diseases as key health outcomes related to physical activity are covered in this chapter. As mentioned before, the field of physical activity and public health began with studies of heart disease morbidity and mortality. The prevalence of these conditions worldwide is a stress point in this module, as well as the dose-response association with physical activity. Let's refresh our memory first. What were the 10 leading causes of death in the United States in 2008? We discussed this question in the first week. Answers are ischemic heart disease, stroke and other cerebrovascular diseases, lower respiratory infections, chronic obstructive pulmonary disease, diarrheal diseases, HIV/AIDS. Trachea, bronchus, lung cancers, tuberculosis, diabetes mellitus, and road traffic accidents. We have discussed some important messages so far. Two main messages are: 1. Research clearly demonstrates the importance of avoid inactivity, and 2. Some physical activity is much better than none at all. Because there is a dose-response relation between the amount of physical activity and risk of poor health. The figure shows the relationship between the risk of all-cause mortality, perhaps the ultimate indicator of poor health, and the minutes per week of moderate to vigorous intensity physical activity. As we can see here, the risk of dying prematurely is lower when one is physically active for 90 to 150 minutes per week versus for only 30 minutes per week. Furthermore, the risk continues to decline with higher amounts of physical activity. Therefore, we conclude that people who are more active are better off than those who are inactive or somewhat active. According to the Physical Activity Guidelines Advisory Committee report in 2008, cardiovascular diseases and the underlying metabolic disorders like metabolic syndrome and diabetes mellitus can be prevented and treated with physical activity. Although people can be independently diagnosed with cardiovascular diseases, metabolic syndrome, and diabetes mellitus, all of these health challenges can, and commonly do, occur together. People with these diseases commonly have other chronic health issues and have not been physically active. Then, what are the definitions of the terms cardiovascular disease and metabolic syndrome? The cardiovascular diseases are a group of disorders of the heart and blood vessels that include the following: coronary heart disease, ischemic heart disease, heart attacks, cerebrovascular disease, stroke, elevated blood pressure, hypertension, peripheral artery disease, rheumatic heart disease, congenital heart disease, and heart failure. Metabolic risk factors contribute to a variety of conditions that increase the risk of coronary heart disease development. Metabolic syndrome is actually a variety of clinical characteristics that have been defined differently by several organizations such as the National Cholesterol Education Program and the World Health Organization, but have the following profile in adults and adolescents: abnormal levels of lipids and lipoproteins, low high-density lipoprotein levels and high triglyceride levels with small, dense low-density lipoprotein, also known as or atherogenic dyslipidemia, elevated glucose levels, hypertension, and abdominal obesity. In terms of the differences between type 1 diabetes and type 2 diabetes. In type 1 diabetes, the immune system attacks and destroys the insulin-producing beta cells of the islets of Langerhans in the pancreas. Type 1 diabetes is treatable with insulin. Type 1 diabetes usually affects children and adolescents. It is also called juvenile diabetes or insulin-dependent diabetes. But it can occur in adults after a viral infection or as post-gestational diabetes in women who become pregnant after age 35. Type 2 diabetes adult onset, non-insulin dependent diabetes mellitus, or NIDDM is related to overweight and obesity and insulin resistance impaired glucose homeostasis. In people with this condition, the pancreas cannot secrete enough insulin to compensate for the which results in high blood glucose and high lipid levels. Numerous risk factors are known to contribute to the development of cardiovascular diseases. In turn, many of these are modifiable with regular physical activity and exercise. As we talked last week, generally there are two types of risk factors: modifiable and less modifiable risk factors. Then, what are the differences between modifiable and less modifiable risk factors? The major risk factors for cardiovascular disease are divided between those that are modifiable, like something can be done about them, and those that are non-modifiable, like not changeable. The modifiable risk factors often can be significantly altered with lifestyle changes or pharmaceutical interventions. Non-modifiable risk factors are often regulated by behavioral interventions such as physical activity and exercise that influence molecular and cellular changes based on individual or clusters of genes. Even though these risk factors have been traditionally thought of as binary, modifiable versus non-modifiable, recent research suggests that this may not always be the case. That is, a person's genetic code for disease may actually be influenced by external factors such as physical activity and exercise. For example, engaging in regular physical activity and exercise appears to affect epigenetic markers such as regulators of gene function that cause the downregulation, repression, or upregulation, enhanced expression of specific genes. This in turn may influence the disease processes. In some cases, a downregulation of a gene or series of genes would reduce risk, whereas in other cases an upregulation would be considered a positive effect. For example, if a person is at risk for developing hypertension because both parents have the disease, by participating in regular physical activity and exercise, that person can lower her or his risk of hypertension and cardiovascular diseases, despite any genetic predisposition. A general understanding of several of the exercise sciences is helpful for understanding the effects of physical activity on health outcomes such as cardiorespiratory health. As we discussed in the past, we focus on three key domains of kinesiology that guide the health aspects of physical activity: exercise physiology, movement science, and the behavioral sciences. Then, what are three physiological, movement science, and behavioral adaptations to physical activity and exercise? From the physiological aspect: lower resting heart rate, greater stroke volume, increased VO2 max, increased ventilatory fatigue, increased arteriovenous oxygen difference max, lower submaximal blood pressure, increased lactate threshold max, improved functioning of autonomic nervous system, improved endothelial function, reduced inflammation due to oxidative stress, increased total energy expenditure, increase in oxidative enzymes, increase in anaerobic enzymes, improved glucose homeostasis, reduced body fat, reduced waist girth, increased muscular strength, increased muscular endurance, lower total cholesterol level, increased HDL cholesterol level, lower triglyceride level. Biomechanical aspects: improved economy, increased motor skill and confidence to engage further in physical activity and exercise. Improved proprioception, which helps coordination system response and balance. Behavioral aspects: increased self-confidence, improved self-efficacy, decreased depression and anxiety, experience with behavioral change, improved stress management, improved sleep patterns. With regard to all-cause mortality, why are the effects of physical activity and exercise remarkable? Only a few lifestyle choices have as large an effect on mortality as physical activity. It has been estimated that people who are physically active for approximately 7 hours a week have a 30 to 40% lower risk of dying early than those who are active less than 30 minutes per week. It is not necessary to do high amounts of activity or even vigorous intensity activity to reduce the risk of premature death. Studies show substantially lower risk of mortality when people do at least 150 minutes of moderate intensity aerobic physical activity a week. Many tests that require maximal or submaximal work levels have been developed and used by exercise physiologists and medical specialists to measure changes in cardiorespiratory fitness or function. The cardiorespiratory fitness measures and tests described here promote cardiorespiratory health and the prevention of cardiovascular diseases. This slide shows the popular cardiorespiratory fitness assessments. Graded exercise testing is most commonly used to measure or estimate VO2 max. Distance run test like 1 mile run, 1.5 mile run, 12 minutes run, 1 mile walk, cycle tests, step tests lasting 3 to 5 minutes. And non-exercise prediction equations are all commonly used to predict VO2 max and have acceptable errors of less than 1 met. It is also possible to estimate VO2 max using non-exercise protocols. It has been evident that an inverse relationship exists between the volume of physical activity and incidences of cardiovascular disease such as stroke, hypertension. Regular physical activity and exercise improve cardiorespiratory fitness and lowers the risk for cardiovascular and stroke by 20 to 35%. We are concerned about the dose-response relationship between physical activity and cardiorespiratory health outcomes. The Physical Activity Guidelines for Americans provide the guidelines for different populations, including children and adolescents, adults, older adults, people with disabilities, among others. In detail, how much physical activity or exercise is required for improved cardiorespiratory health? For substantial cardiorespiratory health benefits, adults should do at least 150 minutes 2 hours 30 minutes a week of moderate intensity aerobic physical activity. Or 75 minutes 1 hour 15 minutes a week of vigorous intensity aerobic physical activity or exercise. Or an equivalent combination of moderate and vigorous intensity aerobic physical activity or exercise. Aerobic activity should be performed in episodes of at least 10 minutes and, preferably, it should be spread throughout the week. For additional cardiorespiratory health benefits, adults should increase their aerobic physical activity or exercise to 300 minutes 5 hours per week of moderate intensity activity. Or 150 minutes of vigorous intensity physical activity or exercise, or an equivalent combination of moderate and vigorous intensity aerobic physical activity or exercise. All adults should avoid inactivity.